Thank you everyone for joining. I really appreciate everyone spending time today with us in the second installment of our Implementation Science and EMS webinar series. My name is Jennifer Fish. I'm an associate professor of emergency medicine at University of Florida College of Medicine, Jacksonville. I'm also the chair of the Dissemination and Implementation Committee for the Prehospital Guidelines Consortium, which is one of the sponsors of this webinar series today. Today, we're hosting a panel of experts in implementation science and EMS to answer your questions about implementation in pre-hospital medicine. I want to start by first thanking the supporters of this series. This educational series was started by the Pre-Hospital Guidelines Consortium. So many thanks to Dr. Christian Martin-Gill and Dr. Chris Richards, who are on today with us, for their guidance and support. Please visit prehospitalguidelines.org for more information about the Pre-Hospital Guidelines Consortium. I also want to thank the University of Florida for providing this webinar format and for providing AMA CME physician credit. I would also like to thank Prodigy EMS for providing CAPC credit for participants. Please note this webinar is being recorded for educational purposes, and we will archive it on the Pre-Hospital Guidelines Consortium's website. To receive continuing education credits, please stay tuned for the last slide for continuing education information. And if you have any further questions on that, you can drop them in the chat to me or email me after. The reason for today's event and for this webinar series is to foster dialogue and discussion on the intersection of implementation science and pre-hospital medicine. Pre-hospital medicine and EMS are very rapidly growing fields, and there are new evidence-based guidelines being generated all the time for a variety of conditions and situations. Yet to ensure these best practices are translated to our EMS agencies and their frontline clinicians requires a systematic implementation science-based approach. Yet, unfortunately, currently in our field, there's not a lot of active research in that area. And so the goal of this webinar series is to identify needs and knowledge gaps, understand what we can translate from other fields to pre-hospital medicine, and to pave the road for future research and collaborations to advance the science of implementation in EMS. Just to frame how we're talking about things today, when we talk about implementation, we're talking about really a translational research cycle where we generate evidence for best pre-hospital care and practices. Individual EMS agencies incorporate that evidence into their standard operating protocols, and then also EMS clinicians on the front line must choose to follow the correct standard operating protocol and its recommendations when treating patients. Today, we will begin by introducing our expert panel, and we will discuss a pre-submitted case and pre-submitted audience questions. And then after that, we'll open it up for live questions from this audience. A note on Zoom etiquette, please keep yourself muted throughout the presentation. And when it's time for live audience questions, you can raise your Zoom hand or you can drop a question in the chat, and I'll unmute you when it's time to answer your question. Also, feel free to keep your camera off if you happen to be multitasking. If you would like a more interactive experience, you can view this presentation in side-by-side mode. If you go to the top right corner of your Zoom meeting menu, click View, and then click side-by-side speaker mode, you'll be able to see the presenter, the person speaking, along with the slides. Fortunately, today we have no conflicts of interest to disclose, either myself or the speakers. I now have the pleasure of introducing our panelists. So Dr. Ramsey Saloom is a colleague and mentor of mine who's taught me a great deal about implementation science. Dr. Saloom is an associate professor and division director for implementation science and health interventions in the Department of Health Outcomes and Biomedical Informatics at University of Florida College of Medicine. Dr. Saloom also serves as the director of the Learning Health System program with the UF CTSI and the associate director for community outreach and engagement with the UF Health Cancer Center. Dr. Saloom's work considers the dissemination and implementation of evidence-based practices, and his research has been funded by the NIH, PCORI, and the Agency for Healthcare Research and Quality. He's authored more than 200 peer-reviewed publications and has also conducted research on implementation in EMS. Our next panelist is also a colleague of mine, Dr. Jennifer LaLauren. Dr. LaLauren is a research assistant professor in the Department of Health Outcomes and Biomedical Informatics at the University of Florida College of Medicine. She also serves as the assistant director of the Learning Health System program at the UF CTSI. Dr. LaLauren is an implementation scientist who specializes in qualitative and mixed methods approaches. Her research focuses on applying technology-based strategies to improve adherence to clinical practice guidelines for tobacco dependence treatment. She is also interested in developing and testing EHR-based strategies to support social risk screening and interventions. Our next panelist is Dr. Lacey Lagrone, MD, MPH. Dr. Lagrone has experience in both the implementation and EMS disciplines. She's a trauma surgeon with graduate training and 8 years of research experience in dissemination and implementation science. Her mission is to limit human suffering attributable to providers not having adequate access to or application of evidence-based medicine. Dr. Lagrone has studied the implementation of evidence-based practices in the global health, trauma, and first responder settings. And she is at University of Colorado. All right, well, we will just jump right in with our first case scenario. This was submitted by an audience member. In this case, should be fairly familiar to those of us who work in EMS and EMS medical direction. And what this person was describing in their scenario was new resuscitation guidelines that have come out from an international organization with high credibility and a very stellar reputation. And these new guidelines advised for adult pre-hospital patients a new type of medication for ventricular fibrillation instead of the more commonly used medication that providers were used to. The guidelines also made a change for the resuscitation of children, changing the recommended ventilation rate for assisted ventilation to 1 breath every 2 to 3 seconds versus 1 breath every 6 seconds. Now, you're a leader at imagine you're a leader at an EMS agency, either a chief or medical director, head of education and training, and you're tasked with implementing these guidelines because your agency wants to stay up to date with the latest evidence-based resuscitation guidelines. But you're encountering some resistance from your frontline clinicians who say they don't understand the reason for the changes. Many clinicians appear resistant to the changes, and you're hearing things like, these guidelines change every few years. Sometimes they just flip back and forth. And so in the implementation science world, we would call this scenario a substitution with a related replacement, which is a very common occurrence when EMS guidelines and standard operating protocols are updated. But as with many changes in EMS, some of these substitution with replacement scenarios aren't readily embraced, understood, or adopted by frontline clinicians, or even by EMS agency leadership themselves. So I'll direct the first question on this scenario to Dr. Saloom, which is, how do you work to achieve buy-in in a scenario where you have a major society and they're updating their guidelines frequently? And so you find yourself making frequent major changes and having to continually educate the frontline providers on those changes.
Great, thank you, Dr. Fish, and thank you for the kind introduction. So it's my pleasure to be here today and be on this panel. I have to say, to start answering your question, that this is not a problem that's unique to the EMS setting. A lot of my work is in oncology and is in cancer-related settings, and we have similar challenges in terms of the clinical practice guidelines in oncology. For example, I'll take screening as an example, cancer screening, where the guideline recommendations change every few years, and they go back and forth, especially when you talk about the age for screening. Sometimes it goes up and sometimes it goes down, and this is understandable for someone who's in research, because these are the evidence is based on population-based models, and so the guidelines and these guidelines bodies to take into consideration what is optimal at a population level. But sometimes that gets lost in translation for practices and for the patients that are seen in these practices. So in terms of, I think, achieving buy-in, and it's crucial to apply strategies that are in general useful in terms of increasing buy-in and maintaining trust and cooperation on teams in general, not perhaps specific to the case of guideline changes. So I think anytime there's a change, it's important for the communication to be transparent. And so it's important to communicate the reasons behind the changes rather than saying that this is a guideline change and it's just happened, but kind of provide more information about what led to the change, and that usually helps in building trust and understanding the reason behind the change. And other engagement strategies could be useful here in terms of involving stakeholders who are involved in the change and implementing the change, having them be at the table when the decision making is happening about implementing the change. So certainly when more people feel like they're involved and in the change, then it's more likely to be implemented and implemented effectively. And then it's I think it's also about dissemination of this information. Again, dissemination of not only what the new guideline is, but also the reason behind the guideline, if possible, and being able to disseminate that in different ways to reach the different audiences that you need to reach. And so I'll stop here, but I think it's there are different strategies. It's any problem in implementation science, we usually look at it as a multi-level problem. And there are multi-level strategies that are needed to be able to support the implementation.
Great, thank you. So following up on that, I'll ask Dr. Jen Lauren, from your viewpoint as an implementation scientist, is there anything unique about a substitution and replacement scenario that potentially could be harder than a whole new guideline or a whole new scenario that has to be implemented? An analogy or an EMS situation would be with the substitutions that we're talking about in this case scenario versus a whole new protocol, say like a sepsis alert protocol. So there's really no change in current practice that has to be implemented. It's a whole new set of things. Is there something particularly special or even more difficult about changing a current practice versus introducing a new practice?
Yeah, I think it actually has kind of its pros and cons. I think about the challenges of introducing a new practice are often just asking people to do one more thing. And that is a huge barrier for most clinicians, or just kind of impact on workload. But when you get to situations like this, when you have a practice that you've been using consistently, maybe the frontline clinicians don't necessarily see a need to change. They're not really observing in their day-to-day practice any downsides. So that kind of points to issues of being able, from an implementation standpoint, being able to demonstrate the relative advantage of a new practice versus the existing practice. I do agree it's hard to unlearn things, and that's certainly a challenge, but at the same time, I think what you can leverage in these cases is that you already have, these are things that are already in the workflow. The processes are relatively similar. And so the substitution aspect, I think, really has to get at both the new practice and then the de-implementation of the existing practice. And I would just, add, as far as doing any sort of implementation work, I think really the critical thing here is the first step is really just to talk to people. So I do a lot of qualitative and mixed methods research, and people will tell you, what the barriers are, why they don't want to use a practice. And it seems simple, and it doesn't, if you're doing research, it's great to do a focus group, do interviews, but really, even for kind of just a simple, like, hey, can we chat for 5 minutes? What is the issue here? How can we address it? And I think piggybacking on what Ramsey said is those conversations also need to occur at multiple levels. So it's not really just the frontline clinicians. You need to talk to leadership and any, if there's infrastructure involved and any changes like with the EHR, that also has to be a conversation. So it can be, And to get to your original question, it can definitely be a challenge, but at least you avoid some of the difficulties of asking providers to do one more thing.
Very interesting. Thank you. And so that leads very nicely into what I wanted Dr. Legron to comment on is, what's your practice for explaining a new change, a substitution, or even an entirely new process or protocol that has to be followed? And maybe if you could just share some things you've learned from your experience that could apply to a similar scenario.
Yeah. Thank you so much. Thank you for allowing me to be here. I think I would just echo that this is definitely not isolated to pre-hospital. This is fundamentally a human brain opportunity that we like black and white and we like crystallized. And so when I think about your question about how do we, if we're introducing something new, our system readiness is much improved if our partners in the system are already bought into the concept of a learning health system. So I think that that's what's part of what's beautiful about dissemination implementation science, is that integral to this new science is a honoring adaptation, pragmatic approach, things that in a historical lens were considered to be limitations. Like if you had to change your plan halfway through, oh, you got to put that in the limitation section. Well, if you're writing for dissemination implementations, you get to put that in the strength section. We were smart enough to change what we did halfway through. And so I think that I 100%, this resonates with me. When I was early in my career, one of my partners, I was in the operating room and I said, hey, are you going to XYZ? And they said, nah, I don't think so. And I said, well, I'm pretty sure guideline says you're supposed to XYZ. And they said, you can find a guideline that says anything. And so that has launched what I spend most of my time doing, which is this for trauma clinical guidance. And I will first also, to all the people in the audience who find themselves in this scenario, you're the chief, you're the medical director, et cetera. First, I want to just say, if it feels hard, it's because it is. And part of why it's hard is because the guidelines are not designed for implementation. So first is that you can just push some of this back on the designers of the guideline, because you're being handed something that is that makes it feel like you've got a huge push, and you do have a push because they're oftentimes not designed for implementation. And when I say designed for implementation, I mean getting those core input in the implementation or in the design of the actual project, so that what comes out of it, they go, okay, well, do you have this resource? Yes, no. If you do have the resource, here's your new recommendation. If you don't, it's okay. We still have recommendations for you. So if it feels hard, it's because it is, and we're working to change the system so it becomes less hard. But then I would say ultimately at the tip of the spear, it's about the knowledge that because a guideline changes over time doesn't mean it's bad, right? It's changing that mindset of having fundamentally a growth mindset, a learning healthcare system mindset that, yeah, it changes, and having a evidence or education around the evidence-based pyramid so that people understand why it changes. So that rather than having that undermine the validity of the guideline, it improves the validity of the guideline when we say, oh, there's another one coming through. And so I would say, if you can, as the chief director, et cetera, do a micro version of what we would hope would be happening on a macro version from a government level or a society level, where you sit down and say, okay, guys, there's a new thing that came out and they're telling us we should XYZ. What do we think about that? Like, what feels easy about that? What feels hard about that? Because adaptation is appropriate and all change is local. And it doesn't mean that you do something different than what has been shown to be the case in a randomized controlled trial or meta-analysis, but it means that you recognize what your system is ready for and what it's not ready for. And that if you don't have engaged co-design of how you're going to implement it locally, then you won't have success.
Awesome points. So much to unpack there. One thing you brought up that I think is worth noting is, although there are many more EMS specific guidelines being researched and created and disseminated, a lot of the guidelines in pre-hospital medicine are multidisciplinary in nature, particularly things like resuscitation guidelines, which are really intended for providers in multiple settings. So, PALS is PALS, whether it's in the ER, the PICU, or the pre-hospital environment. Same thing with ACLS, ATLS. There are some things that, are possible for pre-hospital providers to do, not necessarily possible or feasible for all pre-hospital agencies to do. And so you bring up a great point that the guidelines are not necessarily designed for dissemination, as some people may say, but they're, even if they were, it probably wouldn't, most wouldn't be targeted towards pre-hospital adoption of those guidelines. And the other thing you touched on that I think is worth stressing is that this is even in an ideal scenario, it's going to be a little bit of a messy process to implement something, de-implement other things. And a lot of people in our field are very type A, myself included. And so you like to be able to say, well, this is the new best practice. And then all of a sudden, on your run charts, 100% of your agency's frontline clinicians are doing it and everybody's happy. And that's certainly never going to be the case. So I really love that you stress that some of this is just, it's going to be a little messy, and that's just sort of the way it is. And it is going to be hard because it is hard in some respects. We have an audience question. Any thoughts on how we can encourage more implementation related content and guidelines related to EMS? Lacey, I'll let you tackle that one first, because you did bring that up.
Yeah, I think this is the kind of the frontier with clinical guidance right now, and that there's some exceptional best case, but that it's not the norm. And some examples might be like in the UK, they're really good at having a patient version of the guideline, because you can imagine if you have a conscious patient, it's a lot easier to implement something that the patient is also bought into. And so if they're admitting a traumatic brain injury patient to the hospital, it has on here your loved one might get an MRI on this day, your loved one might be discharged to rehab. And so getting ahead of that, because absolutely having the buy-in of the patient as a partner will improve implementation. The other example that I will just shout from the rooftop that I kind of acknowledged was there's a Colombian neurosurgeon named Andres Rubiano, who came up with, anytime you hear a great idea, you go, well, why haven't we always been doing it this way? Which is the resource stratified part of his first slide of his talk has an ambulance with a CT scanner in it, a regular ambulance as we would think of it, and then an ambulance that we would assume that is the case in a low resource setting, and says wherever you enter our system, we have recommendations for you, because it's all resource stratified. It says like, do you have access to a bag valve mask? Yes, no. If you don't, and so that's the design for implementation piece that to me is a really big highlight.
Interesting. So Ramsey and Jen, do you have any other examples from other disciplines where there are guidelines that are better designed for dissemination and implementation? Yes, maybe so.
Yeah, no, I mean, I can't think of, I'm trying to, think about other guidelines that are more patient-centered, but I mean, I do work with, on the research side, we work with Patient-Centered Outcomes Research Institute with PCORI. We have some funded projects with PCORI, and PCORI requires that the patient-facing material have been reviewed by patients and patient representatives and caregivers. So all of the work that we do does get translated to patients, and so the work that we do at the Cancer Center also, in terms of investigator-initiated trials, we include patient representatives and citizen scientists who review the description of the trials that patients would be asked to join, and make sure that it is the description is something that of the trial is something that the patient understands. So absolutely, it's definitely something that we practice in our implementation research. I have to agree with Dr. Legron that most of bodies that develop the guideline recommendations do not include implementation scientists, and so so the implementation perspective is missing from how do we go from translating the evidence into guidelines to translating the guidelines into practice. So that's probably one of the reasons they fall short in terms of implementation, that they're not designed for implementation.
Yeah, gotcha. Okay, well, let's move on to our next sort of audience submitted question, which deals with a slightly different other part of the translational spectrum, which is getting a guideline out, disseminating it to EMS agencies. And this can be fairly easy in the case of, a very well-known international body whose guidelines are already being used almost ubiquitously. Something like the field trauma triage guidelines, from the American College of Surgeons. When everyone's, most agencies have incorporated those guidelines into their protocols. So when that's updated, they update it. But our field is growing. And so there are a lot of new best practices in the literature and things that might be codified in a less, well-known guideline, or maybe, just described in the literature itself. And so dissemination can be a little more difficult in EMS because agencies, most are not affiliated with an academic institution. Most are, at county or city level. And so in my experience, we have a little bit different kind of dissemination landscape. So Lacey, I'll start with you. Do you have any kind of tricks for dissemination, becoming aware of new best practices or evidence, and then spreading that knowledge?
Yeah, and I think that's another one where you're just acknowledging that right now it's really hard because, somebody wrote a paper of like the average PCP would have to read 160 hours a week to stay up to date on all the things that are relevant to their practice, right? So it is hard. And right now it is a human resource gap, basically, because you need an individual who will do the work of sussing through it and then disseminating it. So like you said, the obvious great examples where it's already happening is like name recognition of ATLS or National Comprehensive Cancer Network. I think apart from that, it is about push and pull, right? So some organizations in pushing, so it's like if but there still unfortunately has to be a human resource person in that hub. So if you're a small organization, we've talked about this even just within our own trauma team, right? We have said, okay, well, you're going to be the person of like, when the new cancer thing comes out, like I only occasionally do a sigmoidectomy for cancer, but you're going to be the one who goes to the meeting and you push that back to the rest of us. So one, I think, is acknowledging it does just take a certain number of hours to make it happen, and dividing that within your small team based on who's interested in what. And then the other obviously is pull, right? Things are more rapidly integrated into practice when there is a very felt need in the community for that. When we lived and worked in Malawi for a year, and we interacted with these Peace Corps guys all the time, and they'd be like, no one's coming to our candle making shops. How do you get so many people to come to your clinics? Well, we were giving out food to malnourished children. So dissemination wasn't a problem of getting people to show up. So I think some of that is that you have a pain point and then you go seek it out. But I think unfortunately right now, until AI fills the gap, or until organization at a meta level spoon feeds us some of this, and there's little pockets of that, like, there used to be a critical care newsletter that came out of McMaster University that I would sign up for. But right now, I think it's that you're dependent on another human in your network to disseminate it, and you can divide and conquer those responsibilities.
Thank you. Maybe Jen, if you could go next, what's some things you've seen in other fields that has been successful in terms of disseminating a best practice?
Yeah, so I think building off what Lacey was talking about, I think establishing learning networks can be particularly helpful, not only in just building kind of awareness of what the evidence-based guidelines are saying, but really how other institutions are implementing them. I think that that idea of like a learning network can really be helpful in terms of just sharing best practices. And it would be really great if, when those are developed, is also kind of those types of groups and networks really kind of disseminating what they're learning too, right? Not just keeping it internal. So I think that, I think just, being able to network and talk to other institutions and develop strategies has been quite effective in many cases.
Thank you. Ramsey, any final thoughts before we move on to the next one?
No, I mean, I think there's opportunities. I want to go back. I mean, these are all great strategies that Jen and Lacey brought up. I think thinking about these within a framework of learning health system, figuring out where we could leverage technology to be able to make this more of a regular process, I think is useful, because not everything is going to be solved with technology, but some of this network infrastructure that we're talking about, whether it's learning networks, or even connecting with the community, with community-based organizations that may be the bridge to disseminating this information to patients and community members. I think now with AI and technology and data science being more available, I think extending that concept of the learning health system to a learning health community is really something that we need to think about how to leverage for dissemination.
And that just reminded me of something, and this is less and more controversial in different areas. EMS is very heterogeneous in our country. Some places, some states have common statewide protocols. And so there is sort of a centralized, mass of people who have more time to dedicate to activities like this. Whereas in other states, other areas of the country, it's a kind of a every man, every woman for themselves type of situation. And I remember as when I was a medical director for 2 agencies, it was up to me to go and see what new best pediatric practices there were every year when we did our guideline updates. And it was very difficult because I had another full-time day job too. Aside from, pulling together in types of consortiums, regional, statewide consortiums, I do think there could be a role of technology in even helping the individual medical director and those consortiums, very quickly search the literature and synthesize it, because the fact of the matter is most EMS agencies have, in one way or another, basically the same type of protocols. There's a certain amount of conditions and situations that most agencies are covering with a standard operating protocol and needing to make sure that their protocols are updated. And while there is some or a lot of resistance to moving to regional, statewide, and even a national type of standard operating protocol, ChatGPT won't be the answer for everything, but there can be some technology-based answers, especially for searching the literature. All right, we're going to move on, and we're going to try and interweave some audience questions into our next couple of pre-submitted questions. So this question is asking about key challenges within implementing pre-hospital guidelines. And so I'm going to kind of subdivide out this question because we have an interesting audience. We have 2 interesting audience questions. One is kind of talking about, what if you have something to implement that's rather controversial, and some people feel the evidence is there, some other people feel like they're not convinced yet, they need to see more studies, maybe the studies that are out there have some limitations, and some people feel that they're just limitations, and other people feel like those limitations are flaws. So maybe if, I don't know, Lacey, if you want to start again, how do you deal with a controversial situation? And maybe if you can talk about one where you are, kind of on the more hesitant side, along with the other frontline providers, and then one where, you see that you feel the evidence is sound and valid, but not everybody feels that way. How would you address that?
Yeah, I think that, in the military context, they're proud of the fact that they practice focused empiricism, which is like early adoption in a standardized way, where they go, we're not going to wait for the meta-analysis and the CPG to come out. Like we got a lot of numbers. We see where these numbers are trended. We're going to leverage them now to benefit our soldiers now. And that works in the military context with all of the hierarchy and infrastructure of the military. Outside of the military context, I think that standardization is for when the level of evidence is high enough that it's as unimpeachable as we can be with our current approach to science. And that outside of that, variability is acceptable, and maybe even it wouldn't be a problem. So an easy example for me is like in critical care, there was like metabolic resuscitation was a thing that started 5 to 10 years ago, where everyone goes, ooh, everybody who's really sick gets steroids, vitamin C, and zinc. And there were some early adopters of that, and there were other people say, that's not really a thing. Well, I think if you want to be an early adopter, it's all about, is the risk low enough that you can put your neck out there for something that is not well enough founded in the literature that everybody's on board, and meaning the risk to the patient. And then if that's the case, Godspeed for early adopters. But I think it's really important because institutionally and locally, we absolutely have been in the situation where someone is trying to push for standardization on something where there is a lack of evidence. that's adequate to have everybody on the same page. And then I think those are efforts that sometimes undermine, again, the validity of guidelines. Because if you're not passionate about evidence-based medicine and guidelines where you're really going to dig into the weeds on this yourself, what you're going to, the experience of that individual is going to be, meh, I don't know, because they're telling me ABCs, airway, breathing, circulation, but then they're also telling me zinc. And if they don't take the time to know the difference that, whoa, zinc, the evidence is here, and ABCs, the evidence is here, you could really undermine the ABCs approach. So I am of the perspective that is keep the, the Pope says in essentials unity and non-essentials grace or something like that. And that's what I think is best for patients in evidence-based medicine.
And maybe that goes back to an earlier theme you brought up, which is that this isn't going to be black and white, and medicine evolves and medicine changes, and some things that are not controversial at all now used to be very controversial. And so, like you said, having grace and trying to get people to buy into that sort of learning cycle. I'm going to direct one of the audience questions to Ramsey and Jen, which is kind of, it's a very interesting one. How do you deal with implementing guidelines for things that are of different frequency and severity? So, just bringing up, for example, the difference between pediatric and adult patients in EMS. In EMS, charitably, 80 to 90% of their encounters are with adults, and 10% are with children. And the vast majority, and this is a topic of my own research, so I'm very passionate about it. 10% of those kids, the vast majority are fairly well, fairly stable. And it's a very low frequency event to have a very, very sick kid that EMS clinicians have to take care of. And so, there are guidelines for very high frequency adult events, and then there are also guidelines for very low frequency, very serious pediatric events. And how have other fields addressed kind of the difference in frequency of presentation or of severity, and are there implementation considerations around that? Or is this something potentially more unique to emergency medicine and pre-hospital medicine?
Yeah, I don't think it's necessarily unique. I think any clinician is going to come across a case that they don't see a lot. They're not as familiar with the guidelines. I think, typically in the outpatient setting, you've got time to look everything up and understand it. So I think in this case, while doing for things that are very commonplace, training and education makes sense, right? And not to say that training and education for these infrequent events is not effective, but I think it has to be supplemented with tools, some sort of reminders, some like a pocket card, because I don't think you can necessarily expect someone to kind of keep all that information in their head and know what to do right away. So I think you have to identify those cases where, these extra tools, extra reminders aren't really necessary. We're already doing a good job of treating these cases. And then where you need to figure out, what kind of on hand, immediately available tools you can provide.
Thank you. Thank you. Ramsey, any thoughts?
Yeah, I think there are differences in the implementation strategies that you focus on, whether depending on the frequency of the event. So for things that are more frequent, as Jen was saying, I think you can have more sort of standardized education, and you can leverage the data that's being generated from these procedures to do more monitoring and feedback based on patterns and trajectories that you see. So in a sense, you can build those, your quality improvement initiatives based on continuous learning from the data that you're generating. You don't have that luxury probably with your events that happen at a lower frequency. So I think this is where you can leverage more thinking about focusing more on having the standardized protocols and thinking about developing algorithms that for these unique cases and thinking about trying to pull the evidence and extrapolate it into into those protocols, but also recognizing that in many of these more specialized cases, you're going to require more specialized training and interdisciplinary collaboration. So focusing on the interdisciplinary collaboration aspect of addressing those cases. And sometimes the training itself requires some patient simulation, because it's less frequent, and also you may want to have trainings that involve standardized patients and other strategies that would be more sort of in the simulation space.
Yeah, that's a great point. And this is something I think that came up in some of our research on pediatric asthma care by EMS is, lower frequency events, providers feel uncomfortable, hard to QA, something that can't happen very often. So there's a role for simulation and a relationship with a subject matter expert, like, a pediatric, in that case, pediatric ER physician at a hospital that the EMS agency transports patients to. So calling in kind of voices of authority that are respected to do continuing education and training for those low frequency but high acuity events. Okay, so we'll move on to our next submitted question, which is kind of ties back in to a lot of things we've been talking about before, which is that many EMS professionals aren't affiliated with academic institutions and don't have access to peer reviewed literature. So I'll let Lacey tackle this one first. How have other disciplines, or maybe your work in global health, how have you dealt with this? And then, maybe if you could just elaborate a little bit more on translating, more dense research papers to folks who are mainly focused on clinical care and aren't necessarily, every day interpreting p-values and study designs and limitations of research designs and things like that.
Yeah, this is another one where I will just say, if it feels hard, it's because it is. The system is broken right now. Everyone has an access problem. Like, I'm at a level 1 trauma center in Loveland, Colorado, and I will log off of the Wi-Fi at my hospital, go on my cellular data, and use a Pakistani stolen website, Sci-Hub, that I learned about in Peru, to get primary literature. Either that, or if I don't need it right away, I can email the librarian who gets permission from whoever who sends it to me. And so I just want to say that is the norm across disciplines. And you can watch the Dr. Glaucomen-Flocken video about publishing ethics. I think this is something, that's why Plan S in Europe exists, that if you get government money to do research, you have to make it public access. There was a lot of lobbying in the US. That is why we're not part of that. But this is a global problem that there's a lot of movement to change. But I would just say, if it feels hard, it's because it is broken. And then how do we overcome the deluge of information and the lack of access to information for people who don't want to spend the time navigating this circuitous route? I would say there's homegrown opportunities, like having a journal club of everyone picks something they're passionate about, brings those key points, and we spend 5 minutes doing it, and you get to benefit from your colleagues. There's journal driven stuff where certain journals, I think most JAMA journals, will have a key points at the top, so you could even just comb of go to Google Scholars, sort for 2024, type in your interest, and then just bring the key points back to your group. And then long-term, big picture, right? This just needs to be done at a bigger level from societies and organizations. And so I'll take this moment to congratulate the Prehospital Consortium for existing, because this is a huge gap, because it will take this type of collaboration to overcome this for the individual providers at the end of this tip of the spear.
Ramsey, Jen, how have other disciplines dealt with this issue? Ramsey, I know you do international work as well, so maybe if you can draw from some of that experience.
Yeah, I mean, we've had similar challenges to what Lacey described. I think in the implementation science field, we recognize these barriers and these real problems, and there's at least for the implementation science journals, they're required to be open access. So that presents another sort of barrier for people who are publishing, that they have to make sure that they have the funds to publish open access, and so the implementation science journals are typically all open access for that reason, but that could be another barrier, especially for early stage investigators who may not have access to the funds to publish open access. But at least from an audience perspective, you're able to reach those studies. And so it's important when you can to be able to publish open access, but it's, I mean, the decks are stacked against us because the publishing houses are in control of that process currently. In the international space, it's similar. I mean, we again try to take advantage of opportunities where the publishing open access is subsidized. I belong to the Society for Research on Nicotine and Tobacco, and they have for that society, they have an entire education program, and I happen to be the chair of their global research network, and a few years ago they developed a what they called SRNT University. So they have a collection of content that is available to members, and they have, you know, subsidized and free membership for people from global settings, from low and middle income countries. So that information, you know, comes at the synthesis of that information comes at a cost. And ironically, during COVID, they had to put that project on pause. But there's a collection, there's a repository of lectures, of published written content that is accessible to people, and it's more accessible to audiences than peer-reviewed publications. So that's one way to go, although that, you know, also introduces another set of problems in terms of the resources that it takes to develop that type of content.
Thanks. Thank you. So in the interest of time, I'm going to open it up for live audience questions. I've already gotten a couple in the chat. So I'm going to tackle one that is actually specifically directed at Dr. LaLauren, because this is about EHR-based strategies. So our audience member writes, many EMS frontline providers do their EHR charting after the encounter is completed or after their interventions have been done. So just, you know, EMS will come, pick up a patient, do things, take them to the ER, and then a lot of times in the ER we have EMS clinicians kind of hang out and do their EHR charting. So point of care EHR interventions are controversial and difficult to implement because of this post hoc charting. Do you have any experience with something similar, or any strategies where we could still use the EHR to help reinforce best practices?
Yeah, I think that's a great point. And it's definitely something that we see in, you know, lower resource settings. Maybe people are still using paper charting. So it's certainly not a unique issue. I think, you know, if you're looking for a way to integrate a technology-based strategy there, even if it's after the fact, you can still kind of include behavioral nudges within EHR documentation. So typically these are things like, you know, you're prescribing a medication and you get a kind of pop up and say, hey, you know, by the way, here are the guidelines. Do you really want to do this? Okay. And then maybe if you still want to go ahead and prescribe something that is in the EHR's algorithm, not guideline adherent, you just have to kind of justify it. And so while that doesn't necessarily work in this situation, I think there's still opportunities for those nudges kind of after the fact on, hey, you know, here's a review of clinical guidelines for next time. I think though, in these settings, you know, it's definitely challenging. And I think that, you know, a lot of times you just, like, technology is, like Ramsey said, technology is not always the answer. Sometimes you have to, you know, go old school and, you know,
Yep.
work with like pieces of paper and posters, and also work more in terms of you know, the professional networks, you know, who, like, do you have a clinical champion who's interacting with your frontline staff, who's kind of talking about this? I think, you know, there are plenty of strategies that don't involve the EHR that are highly effective.
Yeah, that's a great thing to remember. Yeah, the EHR is not always the answer. Okay, Dr. Chris Grabari has a question. Chris, I'm gonna unmute you.
Well, I'd first of all like to thank the panel. I mean, great discussion. You know, being the chair of the verification review committee for the college, when we put out a new optimal resource document for the care of the injured patient, I think we could have definitely learned from many of you. I think one point that I would make is the use of frequently asked questions after your initial implementation finds that there are hurdles for others to get over, and to learn from each other as we implement. And it's really a comment, but I guess I would ask our EMS and emergency medicine folks, have you used frequently asked questions after the initial implementation as a tool, and has that worked for you?
Lacey, you're not EMS or ER, but do you want to tackle that one? I guess maybe a point of quick clarification for the audience. What exactly do you mean by frequently asked questions? Is that sort of a one-on-one debriefing type of thing, or compiling the list of feedback that you get?
Yeah, so this was with a national implementation of guidelines for trauma center verification. And obviously each
Mhm.
place is local, and each place found that they had other struggles or hurdles
Okay.
with consensus guidelines that were put out. And we collected those questions and then tried to have kind of a routine answer to those frequently asked questions, with often including the solutions that that local place found, or and others benefited from it. I think it's just a tool for implementation of national guidelines.
That sounds like a fantastic tool. I'm not aware of anything similar, at least in pediatric EMS. We've got some peds EMS people who can chime in. Ramsey, Jen, is that something you've seen in other disciplines?
Yeah, I've definitely seen it. I think, you know, in terms of my work, I often see that included as part as like an implementation toolkit, kind of expanding on that idea of, you know, I think the FAQ idea is great because it's short and it's to the point, but it's also something that you can incorporate in, you know, resources that are designed to be very comprehensive and guide institutions and implementation.
And Chris Martin-Gill just dropped in, the fatigue and EMS guidelines has a similar example that he's dropped into the chat if folks want to check that out. But definitely something to, if you know any of the audience members are involved in any guideline development, something to keep in mind. It's come up quite a bit. Okay, I've got another a very interesting question. And perhaps since we're 5 minutes to the hour, maybe we can end on this one. And this is, how do you measure success of implementation? And a person asked, you know, in EMS and in other fields. So Ramsey, would you like to start with that?
Sure, yeah. So I mean, in implementation science, we have all these wonderful frameworks and measures of implementation success that recognize our clinical outcomes or effectiveness as a primary outcome if we're on the clinical side of things, but we're also interested in the how in implementation science. So we look at implementation outcomes that may include process measures that have led to the effectiveness, and recognizing that clinical effectiveness isn't the full story in terms of measuring the impact of an intervention. So If we take the RE-AIM framework, for example, it starts with reaching your patient. So are we we may be, while an intervention may be effective for a small portion of our patients, how are we doing at a population level? Are we able to provide that intervention to everyone who needs it? So starting with reach, I think is really powerful in a powerful contribution of implementation science, and thinking about all the different opportunities to improve impact that includes examining the settings that we're in, examining variations and levels of adoption, whether it's at the setting level or with providers. Again, thinking about the dissemination and of evidence and the training that's reaching providers, but then how does that get translated to the patient? So there are different opportunities to act, and it's important for us to understand the implementation challenges at every level. So being able to measure these implementation challenges before we get to just measuring effectiveness at a patient level are really important for us to be able to then act upon them.
Thank you. Jen and Lacey, any last comments in our last couple of minutes? I'm going to fast forward to the CE information so people can work on that while they listen to your final thoughts.
Yeah, I would just echo what Ramsey said. If sometimes we get stuck, if you can't prove mortality benefit, then it's not worth doing, but that measuring perceived appropriateness and reported feasibility is not nothing, and it's worth doing. And so start small, think big, scale fast.
Love it. Jen?
Yeah, I would just add, I think, implementation science has been struggled for and still struggling with, validated measures for implementation, but they are out there for certain constructs. And I would also just kind of going back to the learning health system concept, I think when you're engaged in this work, being very familiar with what infrastructure you have access to and what the data look like and how you can actually measure this when you don't necessarily have a large research grant for primary data collection is important.
Thank you so much. And thank you all for your time. This was really great, very informative, lots of things to think about. Everybody, for CME information, if you made it this far, if you registered, you will be okay. I will be in touch with CME information for you. If you had any difficulties with registration, please just drop your email in the chat, and I will take the chat transcript and be in touch. If you would like CAPC credit, Prodigy EMS is offering 1 hour of CAPC credit. Please scan the QR code or visit the link. If you have any trouble with that, you can email me at jennifer.fish@jax.ufl.edu. I'm going to drop that in the chat right now. Any final, I guess we are at time, so sorry if we don't have time for concluding thoughts, but many thanks to our panelists and speakers for taking the time today. This was an awesome session. Thank you all for joining, and I look forward to the next one.